Thank you, John. As you heard from Michael earlier, I'm Bill Novelli, and I'm in the business school at Georgetown, where I oversee our Business for Impact Center. And other than that, I have a particular interest in the area of advanced illness and end-of-life care. And I'm very pleased, along with Mary and Sandra, to co-chair the Culture, Inclusion, and Equity Collaborative. Now, in this next session, we're going to narrow down from the broader insights offered by our first speaker to discuss AI health tools. We're going to examine more closely how bias can manifest in the development, implementation, use, collaboration, and evaluation of AI tools, and potentially cause unintentional harm. And in particular, the implicit or explicit introduction of human bias, which can result in the creation of skewed data sets that are not representative of populations. This can inadvertently create AI systems and tools that could exacerbate existing health disparities in their design. And to speak more on these issues of bias and ways bias can be mitigated, we have a panel of experts today to provide insight and share their unique experiences within their fields. I'm going to introduce all three of our panelists at once, and then, of course, they will speak in turn. First, I'm pleased to introduce Emily Bembanek, who leads operations and strategies as the director for the Center of Applied AI at the University of Chicago Booth School of Business. And then Varun Mathur, who is a research center at the AI Now Institute at New York University. And Irene Dankwa Mullen, who is the Chief Health Equity Officer at IBM Watson Health. And she was formerly at the National Institute of Minority Health and Health Disparities. So first, let me introduce and turn it over to Emily.
Thank you so much, Bill, and thanks everyone for the opportunity to speak today. I'm really excited to share some of our work with you. So as Bill mentioned, I lead the Center for Applied AI at Chicago Booth. We work under the direction of Sendhil Mullainathan, our faculty director. Sendhil's known for a lot of work in behavioral science, particularly in poverty, development, and most recently, healthcare bias. And I'll be talking about our research in that area today. Next slide. I'll talk about the paper that came out in 2019 that really initiated this work. But at this point in the phase of the research, we are working with a variety of industry partners and policy partners on finding ways to assess and mitigate bias that already exists in algorithmic systems within healthcare today, and then help develop policies and standards that can be used to guide industry on how to create more equitable AI systems, and also to enforce those standards from a policy perspective. Next slide. So I want to talk a little bit about the research that we did and the kind of bias that we're looking at and looking for. And we often think of bias in AI as perhaps a problem of data sets. So you might not have a representative data sample from some groups. I know that came up in the last talk a little bit. Or there are other forms of bias. You may have intentional bias where some groups are specifically discriminated against. In the case that I'm going to talk about, though, this is bias that really comes from humans telling algorithms what to do and not thinking clearly, really, about whether what the algorithm is going to do matches what we're going to use that algorithm for. We looked at an algorithm that's used throughout the country in helping find patients for care management programs. Essentially, you want to find the right patients who are going to benefit the most from this program to place into it so that you can kind of get a head start on any of the flare-ups or other problems that might arise due to their conditions. So what we want to find are the people who need the program the most. But what the algorithm was actually looking for are the people who cost the most. And as you can kind of guess, healthcare need and healthcare cost are not the same thing. We often use healthcare costs or utilization, the amount that people use healthcare, as a proxy for how much they need healthcare, because somewhat intuitively, if you're sick, you're going to go to the doctor, and if you're not, you're less likely to go to the doctor. Unfortunately, for many groups, healthcare access and a variety of other factors like trust and language and all these kinds of things impact whether or not people go to the doctor when they're sick and whether they get the care they need when they actually get there. Next slide. So here's a diagram to think about this. What we call this kind of bias that results in a mismatch when the algorithm isn't predicting quite the same thing that you care about, that's label choice bias. In AI, the label is kind of the variable that is it's being trained on. So the label in our example was cost instead of healthcare need. What the problem that we want the algorithm to solve, that's the ideal target. That's what we care about. We care about healthcare need. But what it's actually trying to solve, who costs the most, that's the actual target. And when those two don't align, we end up with label choice bias. And in this particular example, that meant that Black patients were deprioritized for care versus white patients. Next slide. Here's a graph to kind of illustrate what that looked like when we did an analysis of the actual outcomes on these patients. So you can see here that the purple curve are the Black patients and the yellow curve are the white patients. They should overlap, right? There shouldn't be any difference just based on race on how this algorithm is predicting whether or not you need care from this program. Unfortunately, there is a huge gap. The dotted line on the far right of the graph is the threshold for automatic initiation into the program. If the algorithm scores you that high, like at 97 or so, you're defaulted into the program and you get that care. What this graph is showing us is that at that dotted line, a Black patient, a purple dot, would need to be much sicker than a white patient to get the same level of care. Next slide. So clearly an enormous problem. No one intended for that problem to happen. If you judged that algorithm based on cost, what it was actually predicting, the purple lines and the yellow lines would overlap. It was predicting cost accurately for Black patients and white patients. There was no bias there. What we had to do differently was look at the target we actually care about. What is it predicting based on healthcare need, not just what it's designed for? And that's how we solve it as well. So the way to fix the problem is just retrain that algorithm on a variable that's closer to what we care about. So in our case, we care about healthcare need. Instead of thinking about cost as a proxy for that, we can get closer to actual health. So, if you think about that intuitively, regardless of how much you spend on healthcare, the care that you need depends on how healthy or not healthy you are. And so how could we think about, well, what variables can we use instead of health, or instead of cost, excuse me. Things for health we could use, and what we did use, were things like comorbidities. These are regularly available in the data that we had. You can look at other indicators of health. You can combine that with cost, which we did as well, and create a more varied and complex view of a patient to better predict how much they would benefit from a program like this. Once we did this, once we retrained the algorithm on this new underlying training set, it led to twice as many Black patients being defaulted into the program, not because of any opposite kind of bias or anything like that, but because those were the people who were actually the level of sickness needed for that care. And instead of having to be sicker than a white patient to be defaulted into the program, they were. It was much closer at this point after we did this, after we'd made this change. Next slide. I asked the presenters asked the organizers to share the slides afterwards so you can look at these papers and the history of literature on the topics. This is some of our other work that we've done if you're interested in learning more and interested in the paper itself. The particular paper that I'm talking about today is in the lower left, the Dissecting Racial Bias in an Algorithm paper in Science in 2019. Next slide. So, like I said, we published that in 2019, had a lot of interest from the government, from different healthcare organizations, different policymakers. And what we did over the last year and a half was work with a variety of providers, payers, vendors, a large number of groups to both replicate the study that we did. This kind of algorithm is used broadly, whether it's the same one that we studied or a different one used for the same purpose. It's a very common problem. The other thing we did was work with these different groups on their own problems to see if there was label choice bias in those areas as well. Throughout that process of working with these groups, we were able to develop a playbook for other organizations and for policymakers to think about the problem and implement changes and reforms in their processes and structures to really use our research and do it themselves in their organizations to make a difference. If you go to the next slide, I'll kind of walk through those steps. And just to give you a sense of what it takes to really think about this problem from a practical point of view and make an effort to make change. So, the steps are honestly pretty simple. The first one is just inventory. It turns out that in not just healthcare organizations, but healthcare specifically today, algorithms are being used all over the place, and there isn't usually a centralized repository of information on all those algorithms. They're picked up by different teams, they're purchased, they're implemented, and there isn't always a good process for making sure they're being used in a way that leads to equitable decisions. And so the first step is really just get a sense of what is going on in your organization in terms of the algorithms in use. And then designate a steward, someone who is at a high level in the organization, who can really get the resources you need to follow through with the other steps. Number two is screen. So we work with all these organizations and provide resources on how to actually assess your algorithms. So think about that question I walked through earlier. What's the ideal target? What problem are you trying to solve with an algorithm? Are you trying to find the sickest patients for care? Are you trying to understand which patients should be prioritized for a certain test? Are you trying to recommend screening? Are you trying to manage outreach? There are all kinds of problems and questions you might be trying to answer that algorithms can help with. But you need to make sure that what you are actually trying to do with it and what it's trained to do are aligned. Once you know that, once you have that articulated for all of these different algorithms, you can kind of make a judgment on which ones are more likely to have a potential for label choice bias. In our example, it was intuitive, I think, for those of us who work in health equity, that cost and need are going to create a discrepancy. And understanding what your targets are can help you understand that too. If you have those proxy variables like cost for something that's a little more intangible like need, understanding how those are different in society and in the context that you're in can help you understand where the bias might actually be. And once you have those prioritized algorithms, you can do some relatively simple statistical tests to understand how it's performing in different groups. We walk through this in the playbook and give you some technical examples that I won't go through today, obviously, but it's relatively simple, so I encourage you to take a look. Like I discussed, you can retrain it on better algorithms to match your targets. And then I think super importantly, and not technical at all, is implementing processes in your organization to provide a more equitable structure for implementing, developing, assessing algorithms, and eventually making decisions about care. We view algorithms as a tool to help with human decision making, and so they need to be providing accurate information that can help us make better decisions for everyone we work with. Next slide. Just to wrap up, I encourage you to join our community. We offer a ton of events. We have a bunch of public lectures going on this week, actually. Stay in touch with us. We would love to work with you if you're interested or help in any way that we can. And finally, on the last slide, I wanted to provide our contact information. We're very open to just direct emails, so feel free to reach out to us. Becca Nissan is my colleague here at the center, and Ziad is one of our co-authors at Berkeley. Thanks so much for having me today, and I really look forward to hearing the other panelists.
Emily, thank you very much. That was a really fascinating insight into label choice bias. And now we'll turn it over to Varun Mathur. Varun?
Thanks, Bill. Thank you so much for inviting me over. I have been told that timing is a critical issue. So I am not going to be using any slides. I'm going to provide a very brief overview of some of the work that we're doing at the AI Now Institute on bias, just because a lot of the presentators before have done an excellent job in sort of highlighting some of these key issues. One news event that I wanted to highlight as we have this discussion, and I'll drop the link in the chat here, which is an article to a Wired piece that came out about an AI decision system tool that was being used by physicians all over the United States for opioid prescription. And they track down sort of the lived experience of a patient within this system about trying to get opioids for a chronic disease and illness and can't, because the algorithm is flagging her for the fact that she has, previously gotten opioids for her pets, and that being, shown up in the system, alongside the fact that an algorithm system like that not only was trained on electronic health record data, but was using criminal justice data alongside with it. We talked about secondary uses, and that's an interesting use case. This is a very, when I read this piece, I was shocked and I was angered in some ways, because I think a lot of the things that we talk about in terms of ethics of AI, you could definitely tell right away that those principles were not necessarily used in that case. And the system's called NARTS-CARE. So that kind of springboards into the work that we do at the AI Now Institute. I'm a software engineer by training, but the work that we do on social AI implications of AI is with an interdisciplinary team. So I work with lawyers and ethnographers to try to understand sort of the lived experiences within data sets and how they end up getting used and trained for machine learning. So my specific expertise is looking at electronic health record data. As Dr. Ghassemi is highlighted already, there are some issues with EHR data that can arise. So for example, gaps in individual patient records due to health disparities. Also the omission of behavioral health concerns due to stigma. There's a cultural factor as well that gets captured in these data sets. And then the underreporting of chronic pain due to cultural factors. That's also another issue as well. And so one of the things that we're sort of interested in is at what point do EHRs not become sort of the treasure trove data set that we desperately need in order to sort of quote unquote build actionable insights into a learning health system. And part of the reason for that is understanding the financialization of the process. Obviously, EHRs were not designed necessarily right away for the training of AI algorithms. It's part of billing process, right? And so recognizing those histories is part of what we do at AI Institute, of trying to discern what are the social implications of those systems that we built. Sort of another concern that we have coming out of that are sort of the flawed uses of algorithmic correlation that then get perpetuated into models. So back to the NARCX example in the Wired piece I just shared, one of the use cases, one of the ways that this algorithm is trained on to provide opioid prescription is by using criminal justice data alongside to predict whether or not a patient should or should not be prescribed such medicines. That in and of itself presents flawed use cases, primarily because we know historically criminal justice data is incredibly skewed towards Black and brown populations in terms of incarceration rather than what actually happened. And we see this similarly with healthcare data as well, primarily because for many of the reasons that we think about in terms of what actually constitutes a disease, how do we actually do diagnosis, some of that science is still not necessarily elucidated. So for example, those pathways, I can think of an example in which an AI system for diabetic retinopathy was able to determine the gender of a patient just by looking at sort of the eye, but the patient not being able to know that, the physician not being able to understand that pathway. So what is the computer actually seeing? So in any case, when we think about flawed systems and AI systems making patterns that necessarily humans can't see, are we being reflexive with the science? Are we understanding why that's the case? Because at the end of the day, those learned lessons can already be implemented in clinical guidelines if needed. And so those are the things that we're looking at. I'll highlight two examples moving forward of how AI now has been thinking about combating bias in AI systems, and that we've published papers on. So the first one has been looking at AI systems in global health cases, thinking about how technology has been built in low resource poor settings, and how has technology been adapted successfully in those systems compared necessarily maybe to some places in the Western context. One of the things that we discovered and identified and we've written about is that AI systems or technology systems that were built to improve capacity rather than simply being built to provide a predictive analytics in presupposition of replacing an expert or trying to be an expert in a place that doesn't have necessarily the physician training. Systems that provided capacity building for healthcare workers already on the ground were extremely more successful with adoption. And that's something that we see as an ethical implication because it defines sort of the work area and the work stream and how we want to collect which data and how we want to train models and how we want to deploy them. And the second sort of area of combating bias that we're looking at AI now has been the idea of participatory design, is that some of these ethical implications are incredibly difficult to know way beforehand deployment and then kind of test them and then put them in the wild out there, and that puts patients at harm. You're learning, but you want to avoid that at all costs. Participatory design has evolved as a way to include patients and communities that are affected in the design itself of these algorithmic systems. And we've seen examples of this. Finn Kensing in Denmark has been sort of the champion of living labs, and something that we've looked at going forward, looking at how to create mobile health applications that work for patients and physicians, but using and bringing patients into the design process itself. One of the things that we've noticed, though, coming out of that, and then I'll sort of end on here, is that deploying and building these AI systems is an incredibly messy process, especially when you're considering the patient from the very beginning and when they're there at the design table. So the gold standard example that I use, or what I think about, is sort of Duke Health Systems, Sepsis Watch, that have done an absolute great job of sort of documenting in several different publications what the steps that were taken to even develop and deploy a system like this in their health system. And there's a whole ethnographic sort of report that comes out of it with Data and Society, led by Madeline Eilish and Elizabeth Watkins, that details the issues and the relationship fracturing and rebuilding that happen between nurses and physicians when a predictive algorithm is placed in the health system to detect sepsis. That communication, that workflow, that breakage, all of that is a messy process. And I think finally, one of the things I'll end on that is that the distinction was made between the ideal target and the actual target. Can we sift and find the ideal target and maybe alleviate bias that way? I think one of the things that we're seeing is that the ideal target is not necessarily or cannot necessarily be extracted from who has power within the system. So the ideal target might be ideal for one stakeholder, and it may not be ideal for patients at the end of the day, right? And insurance is probably the key case that I'm thinking about here. So finally, the way I'll end is sort of thinking about algorithms not being extracted from the political health system process that exists. And this was a comment that was put in the chat that I wanted to highlight. I end on Rudolf Virchow's assessment of it, which is medicine is to fill a great task, then they must enter the political and social life. The physicians are the natural attorneys of the poor, and the social problem should largely be solved by them. And I think algorithms are a way to sort of uncover structural bias in the healthcare system. But I think we need to be very attentive on how these algorithms are being used to try to fight structural bias, and if that's possible at all moving forward. Thank you for your time.
Varun, thanks very much. That was really a fascinating look at the complex social implications of flawed AI systems. And now we're going to hear from Irene Dankwa-Mullen at IBM Watson. Irene?
Yes, thank you. Thank you so much for the opportunity to be a part of this esteemed panel. I'm so honored to be here as well. And provide my perspective on key areas where I think we can leverage the potential for AI and machine learning to ensure and really advance our progress to achieving health equity. As Chief Health Equity Officer at IBM, I provide leadership for advancing a culture of health equity, ethical AI, diversity, and inclusion. And so I also work within the Center for AI Research and Evaluation to demonstrate evidence and effectiveness of our data science, advanced analytics tools. And so this includes implementing equity-centered technologies that integrates health equity and social justice principles into our product, into our services, our algorithms and tools, in partnership with our organizations that are also embarking on a health equity strategy. So I feel like I have the unique opportunity to have worked in health disparities research for several years at the NIH and currently working at the intersection of health equity and AI at IBM. So I'm going to make 3 key points in my presentation, areas where we have an opportunity to address bias. The first is underestimation of the translational aspects of AI and machine learning research and development. So basically emphasizing our need to look at AI biases more broadly. I'm going to then talk about the imperative for AI technologies that are aimed at addressing health equity to seek approaches that look at the complex ideological context of a patient health, and anything short of that, I think, will introduce bias. And the third is considering a broader ethical framework that incorporates health equity and racial justice principles along this AI machine learning research and development. So I think that there's a common problem with AI and machine learning studies to date, which is our failure to fully appreciate the long and challenging process in research and development continuum. One that really includes several translational and technical steps from basic science, statistical and computer sciences, to preclinical, clinical outcomes research, even trials and population research. And in any research scenario or development and technical steps that involves AI, machine learning, data-driven insights, I think it's necessary for us to consider these processes and these interventions that will support the translation or the transfer of appropriate science evidence and observations along the AI research and development lifecycle. And this translational aspect is bidirectional. It's not linear, as we know, and so along each of these steps, bias can actually occur. So unless we look at next slide, please. And so we have an opportunity to really consider this translational step. I know that in health disparity science, we define translation, we often talk about bench to bedside. So our translational research occurs along a continuum in various phases, and it could take months to years, right, from discovery to development, delivery, and back to development and discovery. And so unless we develop better strategies or standards around how our science is conducted, how it's reviewed, how it's published and disseminated, to incorporate into our AI and machine learning enabled tools, decision-making tools, we may not be able to achieve that full potential that AI and machine learning has to address health disparities. Next slide. The second key point I'd like to make is that we are not yet maximizing the potential of AI and machine learning to address health disparities. And I agree with Margie and her talk about we're still scratching the surface. Most of our research, for example, reinforce norms of homogeneity among Blacks, Indigenous, or people of color. Segregate all these theories and methods and apply disparate standards to evaluation or interpretation of research on Black versus white versus BIPOC. But we know that these populations or subpopulations have different features. They have different risk attributes depending on where they are or their lived experience that may contribute to either a risk or resilience. Therefore, when we are developing our predictive models or our risk stratification with our statistical methods, with our approaches, we need to be more robust. We need to be more thoughtful and consider the fact that health and disease determinants are multifactorial. Next slide. So that when we're thinking about fairness standards, we need to think about the appropriate reference group for comparison. Is it the general population or is it the socially advantaged population? and ensure that our definition of patient similarity in terms of the features or our variables that are most important are thought through as well, because different definitions can have very different predictions for a given individual. So the key point here is leveraging the potential to really integrate the complete etiologic context of a patient's health. And so our definition of similarity, for example, need to really consider the patient's needs and values, their lived experience or life course experience, and the different determinants of health. For some, it would include geography. For others, it would include racism and discrimination. My third point, next slide, is thinking about ethical AI. And I know we've mentioned a little bit in our earlier talks, and I think this is also an important issue. There is a range of ethical issues that we need to consider when we're addressing racial and ethnic minority population and indigenous populations. And in health and health equity, sometimes our issues of ethical AI is limited, and it should not be limited and really needs to include, for example, accountability, inclusion, a moral agency, empathy, in addition to transparency and trust, all that are ethical issues. So for example, when we're thinking about accountability, we do want to promote accountability to the goals and actions of ensuring equity and acknowledging the values for those groups to which the AI tool will be responsible, which is everyone, including all racial and ethnic minority populations. For example, in human autonomy, we need to respect individual autonomy for racial and ethnic minority populations, and at the same time, understand how the consequences may impact their use of AI within their social context. And there's also privacy, for example, that we heard earlier, considering differential privacy, which warrants certain kind of assurance for protection for racial and minority patients or others who might be more uniquely identifiable. Next slide. So in summary, and so these are, I think this was a slide that I was showing in the key point 3. The next slide, I think. Yes, awesome. So I put this slide in terms of summary, where there are several key areas where bias can be introduced into AI and machine learning development, into implementation and its use and calibration. And addressing biases really needs a systemic, multidisciplinary, collaborative approach. It includes collaboration across all sectors. I know right now there's a lot of work around algorithmic bias, but we also need to really look at translational research bias and human bias and all the different kinds of biases that occur. Next slide. And finally, I can't stress enough the importance of working with communities. I think that we need to work with communities to really inform this framework that we're talking about for ethical and equitable AI and machine learning technologies. We need to think about the dignity of individuals and connect with each other sincerely, openly, engage our communities in a participatory approach for this, and make sure that we're also protecting the priorities of social justice, social values, and promoting health equity and racial equity as a moral and ethical imperative. Next slide. So I thank you for your time. This is my last slide, and a pleasure to be here, and we're happy to answer any questions.
Irene, thank you very much. I'm really glad you brought it down from the science to the communities and the individuals. All three of our speakers talked about the unintentional harm and the challenge of creating and applying a broad ethical framework for AI research and application. And now I'm going to turn this back to my colleague, Dr. Reed Tuckson, to introduce our reactors for this next session and to handle questions. Reed?
Hey, thanks so much, Bill. I really appreciate it. Our two reactors who are going to give us 2 to 3 minute reactions, and then they will participate in the panel discussion. First, we have Sanu Thandane Israni, who is a good friend of of so many of us, and certainly of mine, and executive director of Presence at the Stanford University School of Medicine and the program in bedside medicine. So let me just go ahead and have you start, Sanu, with your quick reactions.
Thank you, Reed. Thank you to everyone who presented. And thank you to NAM for this very important work that they have prioritized and been doing for many years, way before the race reckonings of last summer. So my reflection has to do with the fact that everything we've heard from all our presenters so far is that AI is poised to help the privileged and further discriminate against those who have less privilege. We appear to have a healthcare oligarchy. It is set up in a world which is the reality of colonization, racism, sexism, homophobia, xenophobia, etc. And as long as our focus is profit and market share versus equity and justice, and we have the realities of the structural determinants of life, which is what's baked into all the systems, how do we move forward? Because the assumption within all AI, as we've heard from our colleagues, is the premise is to use what we know to predict the unknown. But what we know is entwined in what I just discussed. So how do we use that to predict a different future? So my overall reaction to everything I've heard is our colleagues are doing a great job of describing the challenges we face. And the big question I have is, what does it take for us to actually have a moral or political imperative to say we need to hit the pause button, otherwise we will continue to exacerbate the existing inequities we already have. I'll stop there.
That was wonderfully and clearly and intelligently stated. I really thank you for those comments. Now let's turn to Nanda Soralas, who is Vice President of Business Intelligence Solutions at CVS Health, for reactions.
Thank you, Reed, and thanks for inviting me. Just reflecting great insights across the board from all the speakers. I think what I wanted to reflect briefly on is from a practical perspective within a business where models, AI are quite widespread, from utilization, care management, as we talked about, marketing to resource allocation. How do you use and how do we use at the moment and think about ethical uses of all those tools? And without touching on everything that was already said, just to add a few more views to that, a playbook we have found is helping us as well. Some standards where we can find a bit our bearings and provide people with some guidance what to look after has worked. I think when we look at an inventory, we have created an inventory. We have found it's important also to look at outside your own company. So there's a lot of vendors that bring in their own models and their own insights. And how do you get your hands and your mind around those and what controls do you have in place to actually make sure that some of the things that come where you don't have as much control are doing the appropriate thing. We have found dedication to be a key component, and again, we're early on in the process, but educating people about ethical AI and how to use different models, what to think about is quite important. It's difficult, if not impossible, centrally to monitor just based on an inventory across the board what's happening, and you need to rely on the people that are actually implementing and acting on those models to have the right mindset and the controls in place to do the best they can. So governance, I think, is important, but somehow let the individual teams and users understand and act. I think the last point I want to make is a bit on data. And the availability of data to help make such decisions. So, quick example: we had somebody, transgender individual, showing up at one of our clinics. They identified themselves as a male, were a female, so based on their birth. And they were looking for a hernia procedure. Our clinics do not perform male hernia procedures because they're more complicated, and pretty much that created a problem. And you didn't actually provide a service that this individual could have had based on incomplete or not perfect information. And I think it's the point there is, how do you collect this information? How do you ask for it? It's a lot of times not easy to ask for this type of information. You might have good and appropriate uses, but how you get to it is a challenge. So these are some of the practical issues, I think, that we're dealing with, and I don't see this as we need to find a solution and we'll solve this, but it's a continuous improvement and learning.
Thank you so much, Nandas. I appreciate it very much. Thanks to the reactors. And now what we would like to make sure we can do in our facilitated discussion is have all of our presenters to come back on camera, turn your cameras on. And we will remind you that if you need me to call on you, raise your hand by clicking the participants button and then pressing raise hand at the bottom. And I will do my very best to catch you. I want to start with an observation that struck me across all of the presentations. Emily started us off with a very complete understanding of this mitigation bias and how important it is to retrain the algorithm once you discover that there is a problem. And so that opened up in my mind the question about, how do you know about bias in time? What happens during the retraining time? And do all of the various AI tools and all the various permutations of AI ML algorithms, do they all have to go through this process of evaluation? Is this practical? The reason why that interests me so much is that as we listen to Irene, she talked about the importance of made me sort of think about how good is good enough. If we've got the added bias in there, and we've got every step along the way of discovery, all the way through to the ultimate rolling up to the AI implementation, and bias is in all of those, how do you kind of know when you actually have something that is good enough? Nandas makes me very nervous in that regard, because he seems to be describing that different vendors have many different models. How do you know what they've got under the hood? How do you know how well they have been connected? And then Varun talks about participatory design. And there, it's, again, very difficult to know before deployment. And so if there's going to be that kind of participatory design, how much work has to go in before deployment? So and then finally, Sonu talks about what I ultimately hear her as saying, do no harm. Let's make sure that before we unleash things on the world, we do no harm. So I wonder how any of you react to that sort of sense that I have, that all of you are ultimately getting at a fundamental question, which really does get to the point of what's good enough. How do you know that you can move forward? Is this whole field going to be stifled because you really do have to do the fundamental checking on bias before you unleash this to the world? Or is the enemy the good, the perfect? Who wants to join in and comment? And I saw Varun.
Yeah, I'll just jump in with brief thoughts. Thank you so much, Reed. And I just want to say, Sonu, your comments are absolutely excellent. I 100% +1 all of that. In terms of retraining, I think there's a growing issue, and this is obviously may or may not be as relevant to the AI context in healthcare as it is somewhere else, but it is computationally expensive to retrain on millions of data points, once you get it wrong. And so I'm thinking about large language models, and particularly if we're thinking about, natural language processing systems that are looking at, word embeddings and such. So it's a computationally expensive tool, and so that might be part of the larger constraint there. I think the question in terms of how participatory design can be relevant in this case, in terms of catching bias or trying to make sure that we've understood bias before deployment, is that the recognition that for most AI systems that were developed with patient communities at the beginning, these were very hyper localized systems that may be biased anywhere else. If they were developed in one small community setting, if they even wandered out of state lines, there would be problems of issues of bias. But because developers, physicians, and patients knew their patient demographics, knew their community demographics, that model worked for them more or less. And because they were able to understand sort of the bias implications and data set shifts that would ensue. So that's one observation that I have from that. I think the other thing too, Reed, I think your question touches a little also on the regulatory barriers and hurdles that exist. I think the regulatory landscape is also biased towards action in many ways, because you can develop these models without any sort of, there may not be a clarity on whether or not these are class 1 or class 2 medical devices. Stat News reported on hospitals developing COVID algorithms without any of that checking. And Andrew Beam from Harvard had a really interesting quote calling it the dirty secret of clinical AI. But those are the things where those regulatory arms would be able to peek under the hood, be able to check the work, the math, and whether or not these systems actually do what they need to do. Those are my high-level comments on checking the bias, but I appreciate the question.
Thank you. Let me turn to Irene, then Sonu, and then Jonathan.
Yeah, that was a good question. And what I wanted to add is we really need a strategic, systematic approach. I think that bias exists more than we think about along the continuum of the research, of development, of human biases in the healthcare system. And I think we can no longer afford to work in silos. We really need to work collaboratively. We've talked about I think we all have one vision. We want to see and maximize the use of AI and machine learning. But this is a point where we need to think about getting a certain level of competency enough to be able to appreciate AI and machine learning and how that can worsen disparities if we are not using it right. So to me, I think there's a lot to be done. I think that unless we get the science and the content, and to get more data sets working with these communities, we will be where we are, and we wouldn't make much progress. So that's where I'm coming from, and I appreciate all the comments that have been made.
Good, Sonu.
Thanks, Reid. So I'll refer to Kate Crawford's most recent book called The Atlas of AI, where she refers to AI as really a registry of power and what it takes to actually build any AI, including healthcare AI, is everything from minerals and materials from the earth to labor to data, classification, affect state, and in the end, power. And the question becomes, who has the power? What are their priorities? Who benefits the most? And who pays the highest price? And in terms of where do we go from here while we wait for governance, which is happening more in the EU than it is happening here right now, it's happening in some states like California. The race reckoning of 2020 created a huge prioritization for diversity, equity, inclusion in many organizations and entities across our nation, including healthcare, perhaps across the world. I would say that the first thing that needs to happen is those DEI efforts need to evolve to include justice. And the leadership and or representation from those needs to be at the tables of AI in healthcare, entwined versus siloed.
Good. Thank you. Thank you. Let me again, Jonathan and then Emily. Jonathan, you're still on mute. I'll come back to Jonathan, maybe. Jonathan, one more chance. Emily, why don't you jump in and we'll come back to Jonathan.
Sure. So I just want to say thank you for the question and the comments and reactions. I agree with everyone. I think like having all the stakeholders at the table, I think Nandas and Sonim both spoke about that, having diverse voices at all levels of decision. I think practically, there is a lot of bias already out there. And so I think there's a couple of things that we need to do. One is fix that problem now. That's very important. And I think one of the positive things about AI is that when you have bias in AI, it is at least somewhat easier to fix it than when you have it in human beings. We can retrain an algorithm. It does have computational costs. There are costs associated with that, but we can dramatically improve outcomes for people quite quickly compared to when we have a societal human system that we're trying to improve. I think that we really need a regulatory landscape that understands AI and that people actually, are held to account for these kinds of things. Right now, it's very much a Wild West situation, and there are those of us who work on it and who understand and try to educate and provide resources. But I think there needs to be an incentivization structure and an enforcement structure that can actually change how the industry is working and how these different actors are making the products that they're making and how they're being used in context.
Good. Thank you. And a real quick comment from Nandas.
Yeah, just quickly, I think I was going to add, and I think Emily or somebody mentioned, it's bias exists, whether it is from humans or from us or from any of the models. I think having the opportunities and the discussions like we're having and being able to air some of those issues and discuss them and try to do something about it. I don't think, as I said earlier, we're going to solve it with one decision. I think it's more an evolving field, and you answer one question, there's still going to be bias out there that's going to come out in a different shape or form. The tools and the AI and the models will learn from it as we're learning along with it. But I think we need to keep at it to have a continuous impact.
We have 3 minutes left in our session. Let me just try to squeeze in 2 questions from the chat. Number one, the essence of understanding the question is, isn't this AI ML information just one factor in clinical decision making? So therefore, while it may have some flaws, shouldn't the intelligent clinician be able to make sense out of the information in the total context of the available information to make clinical decisions? What do you say to that? Yes, Emily.
I think that in an ideal world, that is true, and that is how these may be intended. But I think that physicians and other individuals making decisions work in a world where they have very limited time. And in those situations, people use heuristics to make decisions. And AI and the tools that we develop with AI are intended to condense information and provide simplicity out of complexity. And that means people, yes, could make educated decisions, but that takes a resource and has a cost as well.
And then I think the issue that was so well covered earlier was the sense that you don't know a lot of times until after the decisions have been made, after the data has been given to you and you've made the decision and used it, that all of a sudden you go back and find out, oh my God, it didn't behave as it should have. Now we've got to go back and retrain it. Meanwhile, those patients have already been either triaged or not triaged. The damage has been done. And I think this becomes an issue. One last quick one in the last minute. The very easy question. How do you change the status quo so that future algorithms will be less subject to label choice?
I mean, if I knew the answer to that, we wouldn't have to be having this conversation. I think we're doing it right now. We're making progress, and we're trying to work with everyone around us to understand. And that's education, that's policy, that's technical competencies. It's all kinds of things. And I think everyone using their voice and asking questions like this is really important and fundamental to making a future where we've found new problems to solve because we solved these ones.
Great. Well, listen, our panel ended, let the record state, exactly on time. We did our job, and we will now turn this over to Jonathan for the next session.